story begins about 20 years ago. My oldest daughter was born. And until then, I don't have much recollection of physicians and nurses. But when you have a child, then you begin to see them more and more, and you have a lot of responsibility, and you really care. And then I remember something quite strange. You meet the nurse, and they take the weight and the height of your child, and you're looking at the growing curves and the growing charts. And if everything's all right, then everything is all right. But then you see that you're not really fit in the center of the curve. Okay, what's going on? So the simple question I began with is, okay, that's from children from Tel Aviv or from entire Israel? Is that from the last 2 years or 5 years or 10 years? And the surprising answer was, well, that's actually Scandinavian babies from about 20 to 30 years ago. So are you serious? Don't we have Israeli babies in enough quantity? Don't we have anything recent? What's going on? Yesterday I learned that the guideline to treating depression for elderly above the age of 70 is based on research done on people with depression under the age of 60. Why? Well, the good news is that we have a lot of data, today more than any time in the past, right? We have electronic health records, which is great, and when we go to the physician today, they just type all the time, which is kind of frustrating for them and for the patients, but it gives us a lot of data. This is great. And we also have all the great tools that we didn't have in the past, right? 20 years ago, I was talking data mining, but who thought about TensorFlow or XGBoost, things that probably many of people in the room are using every day now, right? So if we have all that, what's going on? So let me ask you a couple of questions. First one, who in this room is right-handed? Please raise your hand. Great, that was just to check if you're responsive. And you are. How many people here, if they had better access to data, would do good things with it? Please raise your hand. Still a lot of people. So why is it? Well, the answer is that our data currently is locked. And even if we are inside of an organization, when we ask to get data to do some research or analysis, we really have to make sure that we really want to do it, right? Because the bureaucracy and the time until we actually get the data is unbelievable. And we have big data. Every hospital, every HMO have big data in all the right sense, right? The volume is tremendous. Every HMO, just lab results go by the billions, not by the millions. So it's big data. And all the big V's, the volume, the variety, the velocity are there. But how do we get to value? So I want to get to another perspective, what is big data? And there are people like you who can do big things with data and their relationship and access to the data. Now, in this slide, they are apart. Why are they apart? Because currently, we have too many things in between them. Okay, we have the legal and the IT and the data experts, and we need all those people to help us in order to reach the data. And then we don't really have big data, we have slow data. Is that necessary? Most of the things that we do today in order to solve this crisis is to make the work of the people in between more efficient, but this actually doesn't work. But if we can get those people that can think big access to data, then we have big data. So what are the barriers? What's stopping us getting there? Well, we identified 3 of them. One is privacy and regulation. This is actually our health data, right? We don't want our most sensitive data going anywhere, even if that's for good reasons. So we have to make sure privacy is not being neglected. The next thing is that medical data is a mess. Total mess. Each one using different standards, each one using different hierarchies and ontologies. So much of the data is unstructured, as Noah said before. And we're all using relationship databases, and the left join problem never leaves us. And then after we finish all that, there is a limited skill set, because most people in this room probably do not use SQL well and do not program well, and they are reliable on other people to draw the data, even if we solve the privacy regulations and even if we had data organized. So let's tackle those one by one. But the first thing is that's vision. Anyone in this room should be able to ask any question and get the data today, not in 3 weeks, not in 3 months, not in a year, and have that without any risk to patient privacy. And that means that there will be no mediators and no bottleneck away. You will sit in front of your computer and ask for your data and get it. Because if we have those in the middle, then it will not be on demand, it will not be any question, and it will definitely not be any user, right? So how can we solve the privacy issue? Well, usually we use many ways which are de-identification techniques. Be it differential privacy or just simple data removal, aggregation, etc. These are not really working for several reasons. And there are actually risk mitigations. Now, risk mitigations say, okay, that's smaller risk, but it's really for a good cause. The problem with that is that for each de-identification technique, there is a re-identification technique. And that ends with most of us having very limited access to data or restricted access to data. And when we have it, it's expensive, it's time-consuming, it's non-repeatable. You ask for the data, don't come back again. We need many mediators. We're dependent on them, the IT people, other experts. It's a one-off projects, and it involves a lot of bureaucracy. We don't want that. So look at the elephant that should be here soon. The computer is rather slow. I'm sorry. The elephant here is just an allegory, okay? It's a disease. It's acute leukemia in young children. Each pixel is a child. We want to learn about the phenomena, about the trunk, about the leg, about the ears. That's what we actually want. Nobody here in the room actually want to put a Microsoft to see the pixels depicting the children and change them, right? But we cannot have the elephant without the pixels. Most methods today go to create this elephant. Okay, they delete information, and they do hashing, and they do all those very things that actually corrupt the data. Now, the thing about this elephant is twofold. One thing, it's actually the same elephant. It's a 1-to-1 ratio. A pixel here is a pixel there with some noise or other protection measures, which means that if I have the right key, I go back and I find the children. So that's the problem. The second thing here is this elephant is corrupted, right? I cannot do the research as I want to on such an elephant. But actually, it doesn't have to be this way. We can do the other way around. We can have an elephant that looks like an elephant with pixels which are different pixels, which will go up on the screen soon, okay? So we want to build the same elephant, which is good enough for research purposes, but without using the original children, but actually fictitious children, okay? So if I have a group of people, let's say 935 adults with an average age of 37 and some other measures, we want to create a new set of people which is roughly the same size and roughly the same everything, and everything connected. Obviously, we need all the relationship between all variables, all higher correlation to be kept, but we want to get a similar population without being able to go back from any person here to the original person. And when we get a table, we want to get a very similar table. So wherever you sit, you can actually see no difference. And if I have here age and gender and cholesterol and allergies, it should have the same thing. You want data. You don't want aggregated data. But when you do any analysis on it, such as making a scatter plot of one variable versus another, or making a regression, you want to get actually the same result. So the points are different here, but the result should be the same result. One major difference, though. on the left, we have human subject data, and on the right, this is non-human data. This one is highly sensitive, and the other is not. Okay?
If you maintain the data to be close enough to what was original?
That's the whole idea. That you, for research purposes, you should be able to do the same thing as you would done with the original data. Otherwise, what's the point?
But for one patient. If it's an outlier patient, a sick one, we want to...
So we care about populations, not about a single person. A single person, if you want to treat someone, is really important. But if you want to learn about a disease, you want to treat asthma, you need to learn about the population of people with asthma, and not about someone who is really unique, is very different, and have an orphan disease, okay? This is not for orphan disease. Probably the medical data that you use today is based on relational database. And the next picture, if it will come up fast enough, is not an illustration. This is actually a screenshot from one of the queries that you probably use. And anybody who's done such things is usually holding his hands with appreciation of the problem. We don't want that. That's one of the reasons we had OLAP, by the way. OLAP is great. If you have the same question, it can be a very complex question, but the same question coming back again and again and again, OLAP is right for you. You can create great dashboard with it. But if you have a question which is new, you want to wake up in the morning and ask a question, OLAP is not your tool, right? Also, relational database is not really your tool, unless you have time. It will work perfectly, but you will need all those metadata and you will need the time. So here's an idea. How about we'll take all the medical records, but we create it one table per person. Okay? And we create a story. So if that's our question, we want the outcome of diabetics type 2 patients treated for at least 1 year with metformin and failed, and then receive hypoglycemic add-on, etc., etc. And we want to know many things about this patient. We can take each patient and see what's his story. And anything about him can be an event. And so anything about him can be an event. And an event can be a diagnosis with a disease. An event can be a lab result. An event can be getting a procedure. An event could be an admission or a readmission. Anything that you pass can be an event. But once we have these storylines with events, we can ask such questions very easily, right? We go, for the first time, somebody was treated with metformin and failed, and we don't have now to do a left join to fit it with another table. We have it on the same table. Okay? And it's very easy to see if within 3 months or 1 year something else happened or how many times it happened. And then we can both ask very simply and also draw the information very, very fast, not as we used to. And we can also combine it with any type of data. Because once you do it this way and you have your patient story, anything can be an event. Financial data can be an event. Social data can be an event. My Fitbit is also an event. Omics data can also be put. And since we're working with big data today, the amount of data that we have here is actually not a problem. It's linear in size, it's linear in money. That's not the challenge anymore. So this is great. One thing's left here. How many people here in the room are very comfortable with using SQL or many other languages? But just give me the raw data. Not so many people as the previous question. And this should be a room with actually more than average people doing that because we are talking AI people, right? So we do need, if we want to get to this vision, we do need to have a simple web interface where a person can ask the question in a way which is much closer to the way he asks his question as a physician than a programmer would do the things and connect the dots usually. And the last thing I want to talk about today, and I'm ending here, is taking it one more step. Because until now, everything I said is relevant to each data owner at a time. Okay, so Sheba can do it separately, and Ichilov can do it separately, and Maccabi and Clalit and whoever. Okay, but let's say you're treating someone and you want to look at population, and you have only a few, even a moderate size, not an orphan disease, but you have a few hundred people within your hospital. But you know that there are so many people in this world that had a similar situation. Why won't you be able to see them all? If you're from Washington University and you have somebody else from Registry and you both want to cooperate, why won't you do it? Well, today nobody will do it because nobody will take his medical data and put it outside, right? It's too risky. He has responsibility for his patients, but you don't actually have to do that. So you can send your question, no problem asking with your question, anywhere, and people can connect the dots and get synthetic data, which is totally safe, connect an organization, and once everybody has the incentive, this one wants to share data together, you can get a much larger cohort, and then our information and knowledge will be much larger. Once we have that, we're actually liberating data, unlocking it, and we can actually really transform care. Thank you.